Welcome, everybody. I'm delighted to be introducing this webinar today, Learning from Pandemics, A Century of Experience. My name is Daniel Carey, and I'm a Vice President of the Royal Irish Academy and Director of the Moore Institute at the National University of Ireland, Galway. We have an excellent panel of participants, and I'll introduce them in a moment. This is the fifth in our RIA series, Perspectives and Pathways in a Time of Crisis. We've convened discussions thus far on science of COVID-19, on economic questions, issues of social justice, and most recently, the resilience of the higher education system. Recordings of these events are available on the Academy's webpage. I want to thank Jennifer Keneally in the RIA for her help, as ever. She's running the technical side of things, along with Karen Muldowney. And Craig Skerritt of the RIA will be looking after the chat function, so do make your contributions there. We've had more than 330 people sign up for the session. Thank you very much for joining us. Today, we're discussing historical lessons from major episodes of infectious disease across the past century. And we meet at a significant time, with rates of infection climbing in Europe and in so many parts of the world, even in countries that had reasonably successful previous programs of infection control. The global death toll this week was announced as having passed 1 million, according to Johns Hopkins University. The true figure, no doubt, is much higher, and the WHO has warned that 2 million may perish from the disease. And if we need a reminder of the significance of the issue, it came overnight with the news that the President of the United States has tested positive, joining Boris Johnson and Jair Bolsonaro among leaders who have contracted COVID-19. In Ireland, confirmed cases have been at their highest level since April and May. Our speakers today bring a number of historical and personal perspectives on the crisis. Part of the purpose of the discussion is precisely to establish the need for an historical relationship to the crisis to understand and respond to it. So I'll introduce our speakers alphabetically. Svenn-Erik Mamelund is an historical demographer and a research professor at Oslo Metropolitan University. He has 25 years of experience in studying risk factors and consequences of influenza pandemics. In addition to publishing widely on these topics, he has contributed in a variety of different contexts in public media, and for example, in The Guardian, the BBC, Time Magazine, and Deutsche Welle TV. Dr. Ida Milne is an historian of disease, lecturing at Carlow College in Ireland, and a visiting research fellow at TCD's School of History and Humanities. In 2018, Ida published Stacking the Coffins, Influenza, War, and Revolution in Ireland, 1918 to 1919, which was named as a Choice Review's Outstanding Academic Title of 2019. She is a member of the Royal Irish Academy Historical Sciences Committee. She's chair of the Health and Environment strand of the European Social Science History Conference and is co-chair with Professor Martha Narconos of the Oral History Association International Committee. After taking her PhD in 2011 at Trinity College, Dublin, she held a Irish Research Council MSCA Elevate postdoctoral fellowship at Queen's Belfast and Maynooth. And during the COVID-19 crisis, she's contributed in a number of valuable ways to public discussion and understanding, including an address to the Irish Army COVID-19 Task Force. Grace Mulcahy is a member of the Royal Irish Academy and professor of veterinary microbiology and parasitology at University College Dublin. She's also former dean of veterinary medicine there. Her research group currently works to understand how parasites modulate host human responses, immune responses. Prior to her appointment at UCD, she worked on the immunology of foot and mouth disease and was a member of the expert advisory committee advising the government of Ireland during the 2001 FMD outbreak, which originated in the UK. Dr. Michael Ryan is executive director of the World Health Organization's Health Emergencies Program. He's been at the forefront of managing acute risks to global health for nearly 25 years. He first joined the WHO in 1996 with the newly established unit to respond to emerging and epidemic disease threats. And since then, he has led many responses to high impact epidemics. Among his various roles in the WHO, he coordinated their response to the SARS outbreak 2003 and served as senior advisor on polio education for the Global Polio Eradication Initiative from 2013 to 2017. He was Assistant Director General for Emergency Preparedness and Response in the WHO's Health Emergencies Program from 2017 to 19. Mike completed his medical training at the National University of Ireland, Galway. He has a master's in public health from University College Dublin and specialist training in communicable disease control at the Health Protection Agency in London and in the European Program for Intervention and Epidemiological Training. Ida, I'd like to begin with you, if I may. So you have studied, obviously, the 1918-19 flu pandemic, which is often introduced as a point of comparison. And I just wonder, from your perspective, what are the sort of major lessons that you think we ought to be reflecting on and taking away from that extraordinary episode?
Well, I suppose from the very beginning, it felt like a very similar disease in the way that it was covered by the media as it spread across the world from ever closer from Wuhan towards our shores and around the rest of the world as well. And it seemed to follow very much a similar pattern to 1918, both in the way it spread and the kind of way it was shutting down society kind of naturally as it went through, rather than with formal quarantines. There was very little formal quarantine. So I think it has, one thing is that we look at it as an immediate crisis. And the other thing is we look at it as a long-term crisis. I was lucky to interview many people whose family had suffered from it, or who indeed had suffered from it themselves, or who might have lost family members to it. And it shows, like, you know, very much like the long COVID, that people had long-term impacts, both economic and physical and I suppose emotional as well from it. And that we need to remember these also. And then the other things, I think there are many things that can be taken as lessons from 1918-19, like, you know, the socioeconomic groups that it hits people in poorer housing. And we've seen that right around the world. And Paul Slack has written that major epidemics cast a peculiarly sharp light on the societies in which they occur. And I think we've seen that very much with this one, and we did in 1918 too, that it highlights what's wrong with society. In 1918 in Ireland, we had a very overburdened health system, struggling to cope with massive inflation caused by the war. And we have a similarly overburdened health service now. And, you know, again, it's a big lesson that we should never let health get so down to the basics. Our health services should always have some slack in them, that they're able to cope with a crisis like this.
You know, that's one of the questions we might think about, is how there was a discussion about various possible inquiries and whether governments would favor them or not favor them. But certainly that's going to be one of the key questions of that level of preparedness and where investment had been made and not been made. Could you say something about the kind of pattern of illness in 1918-19? I mean, it seems to have affected younger people rather than older people, and to that extent to be a kind of reverse in terms of health consequences of the COVID-19 crisis.
Yes, there were two very specific age groups that it seemed to affect more. One was the under fives, who were a very vulnerable sector of society at that stage, damaged by many different illnesses. 20% of the deaths in Ireland at that stage would have been children under the age of 5 each year. And the other group were young, strong adults. People often say that, oh, it was because they were away at war and they were weakened at war, they were soldiers or whatever, but it doesn't seem to be the case, that they were actually young, strong adults. And there's a few reasons given for this, and Dr. Ryan would be rather more capable of understanding it than I am, but a cytokine storm, you know, an overreaction of the immune system. And the other reasons, I think, is because we didn't have things like COVID payments. So the very poor would have to go back to work and would then die from pneumonias, rather than being able to stay at home until they were fully better. And people kept warning people, once you get the flu, stay in bed until you're fully better, because people die from subsequent pneumonias. And of course, then the other thing is there was no antibiotics at the time to deal with pneumonias.
And do you feel that there was, in your study of it, was there a similar kind of discourse of a trade-off between needing to keep the economy open, or was the pandemic so severe that there simply was no choice, that you just have to throw everything you can at it, even with the imperfect knowledge of disease treatment and mitigation?
There was very little discussion, at least in Ireland, about the economy. Actually, surprisingly little. But I think that's because the economy was already a great concern, because we had this massive inflation coming from the war. It was a time of great industrial unrest already. You know, there were really major economic things that had already happened because of the war. But certainly you can see medicine absolutely working out of its skin at the time to try and come up with solutions, and governments as well pondering, trying to say, the Irish government was quite, or the Irish local government board for Ireland at the time, who looked after our health and generally managed us at the time, they were quite quiet on the crisis. And local government really took control in Ireland, trying to find solutions to it.
Very interesting. Yeah, that's an intriguing pattern, of course. And it's revealed different kinds of geographies throughout the current crisis about the nature of borders, internal borders, who has political jurisdiction, who has health jurisdiction. That's one of the striking features of this moment in time. Yeah, one quick final question, which again, we might come back to, but how would you describe, insofar as you can reconstruct it as an historian, levels of trust in the period of government advice or health advice? Is there a way of getting an angle on that going back a century in time?
This is something I found absolutely fascinating, and I wrote about, the first article I wrote about in the Irish Times was really this really important thing, that governments have to build trust with people so that they can bring people with them for the measures that happen. And you can see this repeatedly in the Ireland of 1918, that there wasn't that trust there, and that journalists are constantly writing at the newspapers, what are the people in the Custom House, which was the seat of the local government board for Ireland, doing about this? And all around the country, newspapers are saying, why aren't they doing something? So there was this lack of trust. They didn't think they were acting in the best interests of the people at the time. And I think we've seen many countries introduce measures, like, for example, our daily news conference, which became so important to keeping people thinking they were informed, by the chief medical officer and his team, and the NEFIT team, It was a really good confidence measure.
Thanks. I'm going to turn to Svenn-Erik, if I might. I know, Svenn-Erik, you've also studied the 1918 flu pandemic, and you bring an approach as an historical demographer, which I think is a very interesting technique of analysis and methodology. I think one of the points that you've raised in some of your contributions are the lessons that we have not learned. So maybe I could put the question to you that way. What are the things that we should have learned that we haven't learned thus far? Well,
yeah, thank you, Dan. My gut feeling is that at least several of the high-income countries, I believe that they have thought that these historical infectious disease pandemics, will only be something that belonged to history, or something that would belong to developing countries, like that couldn't occur in the rich part of the world. That's one thing. And the second thing I think that we might have failed to address is pre-pandemic social inequalities and ethnic inequalities, and also how to deal with those disparities in pandemic preparedness plans. So once again, it seems like, as we saw in 1918, it is the socially vulnerable people. It's the poorest sections of society in terms of education, income, and so on. It's Black people. It's immigrants. The socially vulnerable people. They are once again paying the highest price in terms of the disease burden, but also in terms of the economic burden of the lockdown. And yeah.
Do you think that was, in a sense, predictable under these conditions? Do you think that's something that really was effectively a social and political responsibility to anticipate?
Definitely. And I saw Richard Horton took up this perspective 1 week ago in Lancet, and he talked about this pandemic as a syndemic. And he was borrowing this idea of a syndemic, that term, from an anthropologist called Meryl Singer. And it's saying that this crisis, like the one in 1918, is not simply one infectious disease. It's actually multiple diseases. It's COVID-19, and it's an array of non-infectious diseases, including obesity, cardiovascular diseases, cancer, and so on. Those diseases that we know are giving you a higher risk of a severe disease. And these types of diseases are also interacting with sort of the social inequalities, if you like. So, but what Horton forgot to mention is that these social inequalities and ethnic inequalities also affect exposure to pandemics in terms of crowding, in terms of multi-generational housing, for example. What type of occupation you have. For example, we know now that taxi drivers and bus drivers have been more exposed and more likely to contract the disease. And he also forgot to sort of mention how these social disparities also have an impact on access to healthcare and health information. So it's all of these things, it's the social inequalities are having an impact on exposure, susceptibility, and access to care.
Yeah, I think you raise an important point there, which is partly the necessity of having an integrated perspective. I think one of the challenges is a kind of rush to, understandably at one level, to medics and the healthcare system to solve the problem, but actually not taking account of various different aspects of political culture, of culture more widely, of behavior patterns and so forth, and indeed of those social inequalities and economic inequalities that you referred to. There's another area, of course, which has been proposed repeatedly as a kind of solution, which is essentially a technological solution, that with better systems and tracking and tracing, and if we have smartphones that can be adapted and so on. Are you convinced that that's a remedy, or skeptical, or somewhere in between?
Yeah, it seems like now that we are sort of almost in the same position as we were 100 years ago, because we basically now rely on non-pharmaceutical intervention, isolation, quarantine, and tracing people that might have been infected, right? So we need to think about how to increase hand washing. We're talking about social distancing measures. We're talking about closing down schools, and we're closing down societies. And all these things were also tried in 1918. But we are in sort of a similar type of situation, because in 1918 we didn't have we do have antibiotics today, and we have better healthcare systems and better hospitals and ICUs and so on, of course, and mechanical ventilation, which we didn't have back then. But basically we are seeing now that we are relying on so the toolbox is what they had also in 1918. So yes, I'm looking forward to having a vaccine, of course, but so far we haven't been, able to solve this crisis by vaccines or antiviral medicines or an app, and these things will not solve the economic consequences of this pandemic either.
Yeah, no, that's a good point. Grace, I wonder if I could turn to you. I'm interested in your perspective, partly because of your veterinary background. And my sense is that we have a lot to learn from veterinary science, but it hasn't really been part of the public discussion, perhaps at the level of it might have been. Is that your kind of take on it? Would you go along with that?
Well, as you would expect, I think, Dan, my answer to that would be yes, being a veterinarian. But I would like to pick up on the theme that Svenn-Erik raised there about, the necessity of an integrated approach in both dealing with the situation, but perhaps even more importantly, preventing future pandemics. And as well, I think, as considering the current pandemic or infectious diseases as more than about the relationship between a virus and an individual, it's quite true that other chronic diseases do feed into that equation. But also, as a veterinarian, I'm somebody who espouses the One Health paradigm. And the One Health paradigm essentially expresses the notion that the health of all of us on this planet, be we human, one of the innumerable other species of animals, or indeed the whole environment, ecosystems as a whole, are interdependent. And we can't just expect to understand everything about a disease by looking at the disease in one species. We have to look to other species as well. And so there is a somewhat frightening statistic that something like 75% of emerging infectious diseases in humans have been spillovers from animal populations. And we saw that not only with COVID-19 from bats, but also with previous coronavirus diseases, SARS and MERS, from civet cats originating in bats, and camels being involved in MERS as well. And the same could be true, indeed I think is true, of Ebola, of HIV, of all of those viruses. And it seems that we get these kinds of events when a virus or another infectious organism which has quite a comfortable relationship with an animal host becomes disturbed, moves into a new host, and then causes quite a devastating disease. So to prevent future events of this kind, we really have to look to what we're doing to ecosystems. We have to have surveillance programs in animal populations. We have to be aware of the effect destroying animal habitats, for example, will be on virus infections. And we have to look at the consequences and the dangers involved, for example, in how we produce food of animal origin. And all of those, I think, are relevant to the current conversation and to the work that we will have to do in future to protect ourselves from future threats which will arise.
And would you see wet markets as being part of that issue? I mean, presumably not the only one, but has certainly been attention has been drawn to it, obviously, in the current crisis.
Indeed, and of course we still don't understand the proximate origin of SARS-CoV-2, and wet markets, may have been a factor, may not have been a factor. But I think what we can say without any shadow of a doubt is when we bring multiple species into close contact, particularly outside their natural environment, whether that be farmed animals, whether that be wildlife, whether it be through destroying habitats and having animals move into different habitats, that is something that is a danger from the point of view of a disease, jumping species, and a spillover effect. So those are the kinds of things I think we need to study in much greater detail. And of course, climate change is one other factor that can promote those changes and can change the ecology and the if you like, stable dynamic of infectious diseases.
Yeah. Could I ask you about your work in relation to foot and mouth disease? I think there are probably lessons to be learned from that. I mean, there's perhaps specific to the UK and Ireland and the Netherlands in particular, but are the things that you acquired from that particular outbreak that you think would be relevant in thinking about COVID-19?
Well, I think, Dan, there are similarities and there are differences. Obviously, controlling an epizootic in an animal population, in this case ruminants, is very different from controlling it in a human population. In some ways, it's easier. But in 2001, we were faced with a situation whereby an outbreak of foot and mouth disease occurred in the UK having previously been free of that disease for about 10 years. And the incident or the index case was due to feeding pigs untreated swill, because the foot and mouth disease virus, which like SARS-CoV-2 is an RNA virus, but it's much more sturdy and capable of surviving in the environment, can be transmitted, unlike SARS-CoV-2, really through food. And so this farmer was feeding unlicensed swill products in pigs, and it then spread really like wildfire, particularly to the north of England. We had some cases in the north of Ireland as well, but we were really lucky in Ireland in that, due to the very quick and prompt and vigilant actions of our veterinary services, we only had really a single outbreak, which was in sheep in County Louth in the Cooley Peninsula. But we then had the scenario of how we control this outbreak. And I'm afraid that the solution in that situation was to cull affected animals and to cull animals within a certain distance of that infected animal. So we had the somewhat disturbing sector, not only of culling sheep on those farms which were affected, or farm which was affected, but also sharpshooters effectively shooting deer from the air to make sure that there wouldn't be any transmission. And in the UK, people will have recalled the very disturbing pictures of, burning pyres of cattle carcasses. And I think it would be really interesting to know if public opinion would broach or would allow the same kind of control methods in the future. In the Netherlands, they took a different approach. They had some outbreaks and they did a ring vaccination. And then they had to slaughter those animals, though, because for trade purposes they weren't suitable. So I think there are some similarities and some differences, but certainly I think we can all learn from each other. The last thing I will mention about foot and mouth is that it is airborne, very definitely, and not in the last outbreak, but in an outbreak which occurred in 1981, there was documented airborne spread of that particular virus from Brittany in northern France across the Channel to the Isle of Wight. Which is quite astonishing. And of course, it's not the same with SARS-CoV-2, but certainly we do have to look to, in some pandemics, the route of airborne transmission and the importance of airborne transmission.
Wow, that's a bracing thought. Mike, if I could come to you, and you've been working, as I was saying in my introduction, in this field for many years. I wonder if we could begin with your work on SARS in particular, which is obviously coronavirus. What are the particular things that you took away from that experience that have informed your work and thinking in the current crisis?
Many things. I mean, I think the perspective there, and previous speakers have spoken about that, the journey from the animal kingdom to the human is generally not linear. There's a lot of chance events along that route, and those chances and those risks are increased or decreased depending on what the human species has done, sometimes decades earlier. How we plan and regulate animal husbandry. And it's a little bit like, a space shuttle crash or any kind of an air crash. Some component of the system made 15 years previously and improperly serviced, and in the end, it's all put down to pilot error. But in the end, all complex disasters very often have complex origins, and the seeds of disaster are laid years in advance and in many different ways. And going back to that One Health approach, our ecosystem is either stable or unstable. It has built-in risks or mitigated risks. And I think what the SARS epidemic kind of encapsulated a number of issues. One was that lack of monitoring and management of the animal-human interface, that lack of knowledge of the biome out there, the lack of risk perception. Then when the disease happened, this human, I think, instinct to normalize things. Well, it must be like what we had before. It's chlamydia or it's flu, and persisting with normalizing what was an increasingly abnormal situation in southern China to a point where so many health workers were getting sick and dying that it could not be normal. And that process, which many see externally as non-transparency, and once it gets to a political level, it can become that. Very often it's just confusion as people try to say, work it out as they go along, because we didn't have, as we have now, the diagnostic processes. And then the fact that the disease could spread along a normal pathway, and then you can have these unusual events. Nothing, again, is linear. Someone goes to the Metropolitan, and a disease that has otherwise been proven to be almost exclusively spread by close personal contact and fomites, all of a sudden spreads to nearly 23 countries out of one hotel experience. And clearly there was a different form of transmission there, as we saw subsequently in the Amoy Gardens. So just when you think you know everything, or something else happens. And I think what was remarkable too was the way in which it moved that quickly, but also the fact that nearly 50% of all the cases of SARS were health workers. In fact, SARS was not a community outbreak. SARS was essentially a healthcare-based epidemic with community secondary effects, of how to put it that way. We saw it through the wrong lens. And in that sense, the fragility of our frontline health service, the fact that our health system could act as an amplifier of disease, not a suppressor of disease, I think it was one of the first clear examples of just the very thing you need to protect you. At the very moment you need that system to work, it actually acts, in a sense, unconsciously in that opposite direction. So lots of lessons, but really a sequence of unfortunate events that led to a massive global scare, with a disease that frankly had a very low R naught, or it was not that infectious, and in fact in the end not that deadly. Gave us the scare of our lives, and maybe should have scared us a hell of a lot more into putting in place the systems that address those issues all the way along, from the animal kingdom right the way through to how we deal with the epidemics when they occur. And I think I spent too long, to be quite frank, dealing now with the SARS and the Ebolas and the H5N1s and the H9s and the Zikas and everything else. I'm beginning at times to become somewhat cynical, or at least depressed at the prospect of whether the world will wake up and we will actually see that infectious disease and epidemics are yet another consequence of our poor planetary and ecosystem management, and that in the end we'll be putting out these fires again and again. Some of them will be small, some of them will be large, some will be catastrophic. but we need to find a better way to operate our planet. The user manual is now working, and we need to go back and work out how better to do that. And we in the health system and we in public health are just one part of that that system. But obviously you can see the horrific consequences that we see today of a disease that only emerged 9 months ago, and look at the trail of damages left behind it.
Yeah. Wow, that's some really important points you were just making there. I wanted to pick up on one aspect of it, which is Ebola. I mean, I've for a number of reasons. One of which is, I mean, if COVID-19 had been anywhere near as devastating as Ebola, God knows what the death toll would be like. But Ebola was obviously largely confined to West Africa, and I wonder whether there wasn't a kind of almost a degree of implicit racism in the failure to attend to the significance of this problem and what could be learned from it because it was isolated to that part of Africa. I don't know if you'd go along with that statement, or whether you think that there's that there was some reasonable level of response to Ebola.
I don't. I mean, clearly in the response to the West Africa Ebola, that actually many countries came together to try and help respond to that. But I do think, and this is the case across the board. This isn't just about Ebola. This is about health systems and so many other things. The North and the West, the industrialized countries, have become entirely complacent about the risk of infectious diseases and these high consequence events. And epidemics happening far away were happening far away and of little consequence. And I don't think the industrialized world connected the dots and recognized the threat. I mean, if we cast our minds back, go back to 1996, 97, I mean, the first World Health reports on the threat of emerging diseases were happening in the mid-90s. There were Institute of Medicine reports on the threat of emerging diseases from 1993, 94. We went through it all, and every time we wrote the big documents and we said what a risk and what a threat all of this was. But in the end, we've not put in place the systems to defend against it. We've essentially invested in defense systems aimed at existential threats that haven't materialized, and we've almost put no defense up against the earth-killing things that are there, like climate change and infectious diseases. And I just wonder, in some senses, when you're heading in the wrong direction, sometimes you have to wonder who's operating the vehicle, who is setting the priorities. Because if I go and ask ordinary people on the street, if I want to put a world together for my kids, is it a defensed up world that's protected from rolling armies, or is it a planet with the climate and a social justice system and a health protection system in which they can live and thrive? I think we've got our priorities entirely upside down, and we can do our piece, all of us, you historians and we doctors and nurses, and we can put the band-aids on this and we can explain the entrails of this and why things happen. But in the end, it all comes down to what society invests in. And currently, we have not, are not, and unfortunately, unless we wake up, will not invest in what's needed to stabilize our planet's ecosystem, to stabilize our planet's climate, and to build a safer future for all of humanity.
Eric, if you want to come in on that. These extremely important points that I think in some respects have received attention, but also have been neglected at the same time, partly in the face of the scale of the crisis that we're dealing with. I want to come back to the question of Africa just for a moment, because the rates of mortality there have been so much lower than in other continents. And do you attribute that, Mike, to that experience of Ebola in particular? Obviously, some factors to do with demography of age and climate and so forth, but are there aspects in which public health has been managed there better than in other places?
No, there are many factors. And first, let me say, Africa is a continent of 54 nations. So sometimes we tend to say Africa in that sense. And therefore, the experience in Africa is different. Some countries like South Africa have been heavily affected and are just coming out of it just as bad a situation as many countries in Europe. Other countries have managed to so far get away relatively unscathed. Some of that is down to a very young population profile. I mean, the median age, 50% of the population of Africa are under 19 years old, right? Very, very few people proportionally over 60. So the age, the demographic pyramid is very much set to maybe high incidence of disease and low mortality. And if your surveillance system and your labs are not that strong, then you don't pick up the cases and you don't see the deaths because maybe they're not happening. But that's another day's work. But we also have to look at it from the perspective that countries in Africa deal with epidemics in their stride. At any one time, if I go to any country like Nigeria, I remember last year, actually this week, I was talking with Dr. Chikwe, who's the director of the Nigeria CDC, with some other health leaders, and I said this exact question. I said, Chikwe, how have you guys done it? Nigeria is a really complex country. It's really, dense, and you seem to have, fought your way through this. And he said, we're not out of the woods yet. But, I said, well, what was the difference? He said, look, we just treated this like an outbreak. And I said, what do you mean? Well, we used what we had. We tried to detect the cases, we investigated the clusters, we identified the contacts, we tried to track the contacts, and we just tried to do what we could to break chains of transmission. And we just kept doing that. And overall, it seems to have kept the thing under control. We haven't stopped it, but we've just kept the flames down. That wasn't some big, massive strategy. That was just an instinctive system response, because that's what they did last year with monkeypox and cholera and with Lassa fever and the year before with something else. So that there's a muscle memory in the system that has instinctively goes to community level to try and understand and respond to the disease. Second thing, I think, in an African setting is communities are important. The first thing, and I said this in previous encounters, in my experience with my African colleagues at the front line, very often Western colleagues and colleagues from industrialized countries think technologically first, and then they think about medically, and then eventually they work it out and they go and ask someone in the community, how do we do this, right? It's the last thing. My African colleagues start from the other end. The first thing they think about, no matter how much they're an epidemiologist or a clinician, the first thing they think about is, how is this impacting the community? How are the community going to participate and respond? It is their instinctive first act. And I think that's helped because they've started at that level. So there are certain factors that may explain why Africa may be, in a sense, doing better, but also it's socioeconomically as well. And there has been a great impact of the lockdowns. But I think you're also seeing people are just getting up and getting on with it. I said it in New York last year at the General Assembly, when we launched the Global Preparedness Monitoring Board report, because we were launching the report and everyone thought we were going to speak about vulnerability in Africa and other places. And I actually said, well, actually, in the last couple of months, there have been 2,500 cases of Ebola in Congo. And this morning, everybody in North Kivu got up and went to work. Everyone got up and went to school. I wonder what would happen in New York if there were 2,500 cases of Ebola. In the sense that how do we measure resilience? If you look at this in terms of any metric of resilience, the industrialized world has not demonstrated a whole lot of that over the last number of months. It's not set up for that kind of shock. Whereas African countries, just by dint of the crises they face day to day, they just get on with it. And I know that sounds terribly simplistic, but I think that's in a sense too why Africa is perceived to have done better than others might have expected.
We've had all sorts of different questions and comments coming in, so I wanted to kind of pivot towards some of those questions now. Maybe the first one that came in, I direct this to Grace, is really about the need for communication between veterinary medicine and the other medical professions. I assume that that's something that you're in favor of. I mean, how might we facilitate that to happen? Are there mechanisms in which that can take place?
Well, I think to an extent, Dan, it is happening. And there are examples, there are pockets whereby there are very close interactions. So, for example, antimicrobial resistance, AMR, is a big problem globally. And there are causes which are centered in veterinary medicine, the use of antimicrobials, antibiotics in veterinary medicine, particularly in livestock, as well as, improper prescribing and perhaps, too lax controls in human populations. And I would say that is one area where there is very close cooperation between human and veterinary medicine. But I think there is scope for far more. And I think particularly in the context of preventing the next global health threat, I think it's something that we really need to work on far more. And, the old adage, prevention is better than cure, certainly is true in this situation. And so I think if we can devote the kinds of resources, or even a fraction of them, that we have devoted to controlling the current pandemic, to preventing the next one, I think that will be really productive. And we all need to let go of our backgrounds and our ologies and our, professional isms, if you like. This is a global crisis. There will be further global crises, and all of us need to work there. So I think there are roles for everybody, from veterinarians, ecologists, human medicine, public health specialists, economists, all of those kinds of people. And I would hoping that Dr. Ryan might tell us something about how the structures could be built to help that happen internationally, whether he thinks there are good structures internationally.
Yeah, we're just losing touch there at the end, Grace. But actually, maybe I will just ask that question to Mike directly. It was certainly one that I wanted to think about. Are those global structures in place? What can we do to enhance and strengthen them? This has obviously been a story partly of a global pandemic, but of nation states and borders at the same time. So I don't know if you help us about that question.
I think obviously there are two issues here. One is the global scientific public health, the architecture of anthropologists and others around the world who want to work together to better contain disease and understand disease. And I actually think there's been an unprecedented level of cooperation between the public sector, the private sector, the academic sector around the world, right the way through this. And when you look at this and we compare it to other diseases, it took us years to identify the cause of AIDS. It took us months and months to identify the cause of SARS. To think that we were sequencing the virus, getting assays, we were within 2 weeks of the virus sequence being available, we were actually making diagnostics. So we've made huge advances in the science, and I do think there are still better structures we can have, certainly around One Health and the animal-human interface and that joint approach to that. I think that requires a much higher degree of enhanced cooperation between FAO, the OIE, WHO, and other animal health and virus discovery organizations. I think that's a big area that we need to work on. And I know we're coming up to the One Health Congress that was supposed to be held in Edinburgh. I'm very disappointed that it's not. It is being held virtually, and it's just as important because we need to speak together now about the implications of this event before it ends and everyone forgets it and gets collective amnesia again. But I think the biggest disappointment in this and the biggest lost opportunity, and the question has to be asked, is the level of political division, the lack of political leadership has an impact. The reality is that, we have struggled to bring countries together to implement in a coherent way. We are struggling to raise money for the accelerator for COVID tools. I mean, think about this. For $32 billion, we can develop and distribute that solution, potentially a vaccine, equitably to everyone who needs it in the world, and further scale that up, right? Compare that to the trillions of dollars that's been poured into economic mitigation. We're currently, I think, at $3.8 billion raised against that. We're less than 10% funded against this massive effort, a Marshall Plan like you've never believed. Private sector, public sector, the Gates Foundation, WHO, UNICEF, Global Fund, everyone putting aside their differences to try and make that happen. Yet, the cavalry isn't coming in terms of the finances. So that maybe tells you the G7 or the G20 can't agree on public statements regarding this because there's so much division in the world around what we need to do about this politically. And that has to be seen to have an impact on the cohesion of the health response. And I do think governance and political leadership has been a major issue in this response. And much and all of going back to the 1918 pandemic, one of the things that really interrupted proper measures there was actually the First World War meant that there was so much suppression of information because of the need to manage information related to the war that people didn't get the information they need. So they had an under delivery of information. We're now in the land of misinformation and infodemics, where we've not only confused, we have fractured society. We have created massive conflict where there's no need for it. You know, there's been a manipulation of human attitude when it comes to this pandemic, and we're just fighting to maintain the scientific voice in the midst of political catfights. So I find that quite difficult myself personally. We have to persevere, but a little bit more. And there are some great public leaders out there on the political stage, Angela Merkel and others, and the Prime Minister of New Zealand and others. I might actually add that the only thing I know that maybe if you put it to statistical significance is some of the best political leadership I've seen in the last 9 months has come from women. And maybe we need to think and reflect a little bit more on that, and what is that leadership style that actually brings a society together during a crisis and builds bridges and trust between people in order for us to collectively respond.
Okay. Svenn-Erik, I think you might want to come in.
Yes, I've been thinking about these social inequalities for many, many years, and I did one study in 2017 looking at pandemic preparedness plans and whether they took social inequalities into account, and they did not. So I was thinking, why would that be the case? This was in 2017, and I found that most of these plans have been written for high-income countries. Would it be the case that they are mostly concerned about reducing social inequalities in health in non-infectious diseases at the expense of infectious diseases? And do they believe, those that write these plans, that beyond medical risk factors, everything is socially neutral? Just like Madonna said here this spring, that this is the great equalizer. Everybody's in the same boat. Is it so that there's a lack of this perspective because most of them that write these plans are medical doctors coming from the hard sciences? Very, very few come from humanities and social sciences. And I think Mike talked about this paper that came out in British Medical Journal yesterday about a lack of women in all of this emergency pandemic preparedness committees around the globe now. So I think, okay, so we lack perspectives that sort of are that women can bring to the table, and also humanists and social scientists.
Yeah, I mean, that's a message that I'm very keen to reinforce, not least because I run a humanities research institute, but I think, again, that's consistent with what we've been talking about here, I think very usefully about the integrated approach, and it applies to One Health, but also intellectually and critically and socially our relationship to these problems. I wanted to come back to you because it was actually, Mike referred to this prospect of forgetting, which is also so much part of the mix. And that's an understandable psychological response to dealing with crisis. And no doubt it was that much worse in 1918-19 in the context of the war and so forth. But what's your take on forgetting? Does it make you think that we're likely to try to put this behind us as fast as we possibly can, whenever that may be?
Yeah, I think this is my biggest fear now, is that when it comes to the end of this crisis, we just say, oh, thank God, that's over with, and we just forget and go on. And then we'll run into the same thing, perhaps rather quicker than we have. There won't be 100 years before we have a crisis on such scale again. I think it'll happen rather quicker, unless we wake up, as Mike says. We really need to have that slack in the system. We need to have stockpiles of certain things. We need to think about making societies around the world healthier in general. We need to think about social inequalities, as Svenn-Erik has been championing for years, trying to get them national pandemic plans to listen and to include these, as well as medical comorbidities, into the system. And indeed, we have a question on there from Peter, who's asking why we haven't looked at that these things were known in the Russian pandemic in the 1890s, which he's now studying for his MA. And, the thing is, we possibly are not that good at communicating about them, and we all need to learn to communicate better. And academia tends to shut away its research, or at least the humanities side has. And we need to get much better at getting it out into the public domain and discussing it on forums like this and using it, and you know, making sure that our research is well known and communicated well.
Yeah, no, I think we've been in, you know, there are lots of, we could discuss that in a separate kind of context about the conditions in which that's prevailed. There are many factors, and you're absolutely right that it's both academics being reticent about it, but also the appetite for that information being not quite what it should be. I want to come to this rather troubling prospect of okay, let's say, you know, a vaccine is suddenly found. It might be in Oxford, it might be in, you know, it might be in China, it might be in a variety of different countries coming forward. There's obviously a kind of growing movement of anti-vaccination that's out there. And this would be a very good example of precisely what we've been talking about, that it's not insufficient just to say vaccine has arrived, problem solved. Now we have another social problem. So, I mean, I guess maybe it's a question initially for Mike. Is that something that the WHO is working on, or do you have a plan for? I mean, you were talking about this kind of fundraising deficit in this domain, but what about the actual implementation of it if the funding is there to produce the vaccine and make it available? How about social acceptance of vaccines? Is that something you're worried about?
Well, very concerned about it, and unfortunately, it's even worse than it might otherwise have been with all of the various sort of stoking of, you know, I mean, people always have a hesitancy. I mean, who isn't hesitant about anything new? You know, so vaccine hesitancy is not a disease, and vaccine hesitancy is not wrong. One should always hesitate before you accept anything into your body. You should always have information. You should be able to make an informed choice about your health. And what we have seen over the years, that the single greatest life-saving intervention we've ever developed, other than social justice for disease, is immunization. And if we look at the great health movements of the 19th century, billions of lives, or probably millions of lives, were saved by basically water, by proper housing and other things. And then we waited for the era of maybe antibiotics, and immunization was really the next. So immunization in itself is a very good thing. But people have genuine questions, and we needed to be able to engage with communities in a non-politicized environment. Unfortunately, that's not what's going to happen now. We're going to have to engage with communities in an intoxicated and politicized environment. And that's an uphill struggle, and one that we just have to accelerate and take on. And I think we need to invest now. We need to invest lots now. And there's one thing, as a colleague of mine said recently, it's not vaccines that matter, it's vaccination. Vaccine is no good in the vial. So the conversion factor from a vaccine, and it has a major impact, because let's say we get a vaccine of 70% efficacy and only 40% of people take that, then we're going to have 25% of the population protected. It's not going to do anything. It may help a little in terms of transmission, but a lot of very, very vulnerable people are not going to get the vaccine. There are two issues here. One is the vaccine as a mortality reduction tool, which is about getting the vaccine to those most likely to have a negative course and die, which may be very much our older and more vulnerable populations, versus the vaccine as an epidemic control measure, which requires you to vaccinate at much higher levels in order to interrupt the dynamic transmission of the virus, and that's the concept where you need to reach the number that is considered to be representative of herd immunity. Although that wonderful word has become very tarnished as well in the last number of months, as it's been kicked around the place like a football. So from that perspective, the most important thing in the first wave of the vaccine rollout is that we identify those most vulnerable, and that's usually in the older population. And we have to work there now, because they're the people whose lives can genuinely be saved by this vaccine, even if the vaccine is not fully effective. And we often see with vaccination as a life-saving intervention that while it may not prevent infection, very often vaccines will prevent a severe course of disease. So if we look at that, so I think we need to prioritize also our work on vaccine hesitancy and acceptance, along the lines of our strategy to roll it out. And I think then if we can demonstrate that we can save lives with that vaccine in that demographic group, I think that will bring more confidence from younger people and others. So I think we need to be really clever to align our strategic approach to rolling out the vaccine with strategic communications to go with that in advance. In other words, we almost need to immunize the vaccination program in advance against the untoward effects of misinformation down the line.
That's extremely interesting way of putting it, but it also again suggests that we have to have a really coordinated campaign here, and that it isn't sufficient by any means just to have a kind of the medical response, the kind of research laboratories that are producing these things, crucial though they may be in the future.
You also need to storify, Dan, and I think that's something that the research on vaccine hesitancies showed over and over. The work I do myself, retelling not just the story of the Spanish flu, but capturing stories about people who've perhaps been made deaf by measles or something like that. And people understand stories that they can identify much better. And I think this is a very important part of how we, again, will build trust and understanding about with the vaccination program.
Definitely no. And if you look back to the kind of height of the crisis, in its first phase, so to speak, or the early months, maybe a better way to put it, it was very much through storytelling. I think the importance of journalism and various different media platforms has really been crucial to try to engage that. And you have to refresh those stories to create the human interest dimension to it, because otherwise these become very abstract sorts of figures and scenarios, and people psychologically adjust to that, as they probably have to do in any kind of, onset of a crisis situation.
People don't see themselves as being part of the statistics, but they will identify with the story.
Yeah, Grace, I wondered if I could ask you a question, which is really because of your wider medical background about the healthcare system. This is one of the questions that come in, and whether this is really a story about the difficulty facing healthcare systems more generally. Is that something you would go along with, or do you think we need to concentrate on other questions and thinking about the COVID-19 crisis?
I'm not sure that I really have any competence to answer anything about healthcare systems, but I do think, and just referring back to an earlier point in the conversation, that perhaps because we're more used to these kinds of disastrous infectious diseases affecting the developing world somewhere over there, now that it's affecting us in Europe and North America, maybe that's a small glimmer of hope that we'll begin to take things more seriously. I think, for a long time, it seems to me that in the medical curriculum, infectious diseases have not been particularly well highlighted. There's a lot more discussion of lifestyle diseases and so on. That's not true in veterinary medicine, by the way. But perhaps this now will be kind of a resetting of the system, and perhaps the fact that Northern Europe and North America has been so badly affected will encourage us all to think more strongly and more strategically about the kinds of things we need to do to prevent future events. And it certainly has highlighted, as Sven has alluded to, the kinds of economic inequalities that we need to build in. But of course, the healthcare systems in Scandinavia are very different from the ones in North America. And again, we could discuss that forever in a day. But I do think the fact that the developed world, if you like, has been affected might be helpful in us taking these kinds of things seriously in the future.
And would it be true that veterinary medicine is more attuned to questions of infectious disease in general terms than, say, the medical profession on the human side would be?
Yeah, I think it is, because of course, although in veterinary medicine we use antibiotics just as we do in human medicine, as a proportion of the kinds of things the veterinarians deal with infectious diseases are much greater, it seems, than in human medicine. When we're talking about livestock, whether it be for good or ill, our animals don't live long enough to get the kinds of cancers and cardiovascular diseases and so on that we see in human populations. In pet populations, they very much do. So there it's a more balanced situation. But I think in veterinary education, the kind of setup is such that we do very much take a comparative approach. And veterinary public health is a specialism in its own right, and it studies things like how foodborne diseases happen, be it directly from animal products or via vectors. We study vector-borne disease. Malaria, for example, is an example of one important in humans. There are many others transmitted by insects and by ticks. So I think, and perhaps it's a reflection of the fact that we're a younger profession, dating really only from 1761, and maybe that's because we haven't evolved as much as our colleagues who study human medicine. But I think in general, we do probably put more of an emphasis on infectious disease, yeah.
Maybe I could just cut in here, because one of the things I think that very interesting contribution of veterinary medicine to my field, some of the finest epidemiologists in the world are actually veterinary epidemiologists. In fact, Paul Fine at the London School and others. And it's really interesting how vets are actually taught about population health from day one. The population matters, because a herd of animals of economic importance, if one animal is sick, the risk of economic disaster is immediately obvious. We don't think the same way about humans. We have this more human, individually centered, not socially centered view of disease. We don't think about the consequence to the group. We think about the consequence to me. We've set up our health insurance systems to reflect that. We've set up everything to reflect that. We run our healthcare systems at 99% occupancy, or sometimes in Ireland at 110% occupancy. And we think there's going to be some elastic left when something bad happens. Think about it. Our systems are designed to fail. A great mentor of mine, Sir Liam Donaldson, the ex-chief medical officer in the UK, once said to me when I was complaining bitterly in Pakistan trying to eradicate polio that it wasn't working and we weren't getting the right outcomes, and he basically, chided me and say, "Hey, Mike, your system delivers exactly what it was designed to deliver. Stop complaining, go back and find out what's wrong." So I think we need to maybe accept that this event tells us something is deeply wrong. And it's not just one thing. Correct. There are many things, from social inequalities to the way we look at the animal-human interface, to the way we deliver healthcare. All of these things are contributing to an unacceptable risk to human civilization. Now, how do we manage that together? Because there's not one sector going to solve this.
That's a very powerful message. We're kind of coming to a close. I wanted to have a couple of quick final things. One, I thought I might ask Svenn-Erik this. There was a question earlier on about whether we are doomed to repeat our mistakes. I mean, a somewhat depressing thought, but obviously one we have to contend with. I mean, the basis of your historical research, are you optimistic? You're obviously keeping up the fight, but where do you think we might be headed in that respect?
Good question. Well, I certainly believe what we can do ahead is again, I'm going to return to the question of social inequalities. We need to, reducing social inequalities in every way is actually very good preparedness. And secondly, including social inequalities in these pandemic preparedness plans, in addition to medical vulnerabilities, is something that we need to attend to. We need to think about if we get a vaccine, we need to think about the socially vulnerable in addition to the medically vulnerable. So it's not only going to be a question of if you have a cancer or a heart disease, you need to think about social vulnerability as well. Look to Germany. When they were thinking about how to open the society after their lockdown, they asked philosophers, school researchers, priests, a number of other people that are traditionally not part of these groups, to think about how to open a society. Because if you're going to open a society after a lockdown, that's not only an issue, it's not only a medical issue, it's a social issue as well. It's about kids returning to school. There's just this number of other issues as well. So look to Germany, think about how to broaden these groups that are currently thinking about preparedness.
Yeah. Mike, I wanted to come to you for the last sort of comment, and maybe it's a question, an obvious one to ask you about the trajectory. We've been talking about the lessons from the past, but you're in a unique position amongst all of us here. Your thoughts on where we're headed at the moment, if you might.
Yeah, it's a tough one. If we look at look at all of the available seroepidemiologic data from around the world, which is our best guess at how many people have been exposed and been infected, it averages out about 10%. It's higher in some places, up to 20%. It's much lower in other places. It's higher in urban versus rural areas. But if you take that, about 10%. So that means about, what, 750 million people around the world have probably, in some have seroconverted to this virus. That sounds like a hell of a lot. The problem is there's over 6 billion left. So therein lies our problem. Now, we know that there may be some innate immunity. We know there may be some cross-protection from other coronaviruses. And we know that this concept of vulnerability is not linear. The disease moves along certain pathways of risk. So we don't know what that magic number is for transmission to be affected. But we know 10% is not that number. So we're in for a hell of a ride for the next 8 or 9 months as we await the arrival of vaccines. And I believe we will get vaccines. I believe they will not be silver bullets. I believe they will be, like most vaccines are, an additional tool that should be added to a comprehensive strategy to fight this disease. And that includes a social, economic, and a biomedical strategy to reduce the impact of this pandemic on people's lives, not just on their health. And we have to find those balances. So I think that's the trajectory. I think the thing I would say most is too, for something like the likes of Ireland, is we just need to also count the losses in older people in the last phase of this pandemic. We really have to protect older people with underlying conditions. We cannot allow the long-term care facility issue to become the driving issue of death and mortality in Europe this winter. We had it the last time. It should not have to be the way this time. If we look at avoidable mortality in this last phase of the pandemic in Europe, much of that mortality was amongst older people living in long-term care facilities. And therefore, we need to really focus on ensuring that we protect those and support the staff who work in those institutions. But people call me here, one of my senior managers calls me a pathological optimist. I don't know what that says about me, but I've been through a number of these epidemics, and I actually have hope. I actually have hope, in a sense, that we might finally wake up to the climate risk, to the risks presented by social inequalities. Social inequalities are in themselves awful, but they represent a threat to the future stability of our world, both in biomedical, political and social terms. We need to look at that. We need to look at tolerance and racism. We need to look at biomedical risk. I think a lot of this is converging, and we're seeing this convergence of risk. We're all heading headlong, social inequalities, animal health, human health, climate stress, and we're all seem to be heading headlong to a disaster or to a new realization. And I'm not quite sure which one it is yet. I'm really hoping it's the second one. And I believe it can be, because I think we owe it to our kids to hand over a planet in better order than we're doing right now.
Thank you very much. Extremely powerful message. Yes, disaster or a new realization, I think, is no better way to end our reflections. This has been a fantastic panel. I want to thank all of you for participating. Sacrificing time. Mike, you're obviously battling all sorts of challenges on a daily, hourly, minute-by-minute basis, no doubt. So thank you particularly for joining us from Geneva. We wish you the very best in that work, and thank you for your contribution. Thank you to Svenn-Erik, to Grace, and to Ida as well. This has been a wonderful session, and I think some really powerful, important, and necessary lessons. So thank you again.
Thank you, Dan, for organizing.
Thank you. And thank you for great moderation.
Yeah.